name is Ella Kate Marisi, and you are listening to More Than Child's Play with your host, my mommy, Lacey Marisi, and my Aunt Nicole Surgeon. They are authors, therapists, and most importantly, mommies. And man, can they talk. So sit back and relax and learn from their village. We hope you enjoy the show.
Hi, everyone. Thanks for coming back to the More Than Child's Play podcast. My name is Nicole Surgeon. I am the physical therapist of our duo, and I'm excited to bring you an exciting episode today. Before I get started introducing today's guest, I just wanted to remind you, if you have not followed or liked our podcast, wherever you get your podcast, we really appreciate that follow. For a small podcast and a small business, your likes and follows and reviews mean a great deal. So if you wouldn't mind doing that, we would really appreciate it. Today, I am thrilled to bring you Liesa Ritchie-Persaud. If you are a physical therapist, you likely know her name, or an OT as well. She is an absolute expert in her field of study. So let me just tell you a little bit about her. She is a doctor of physical therapy and a pediatric specialist. She is licensed with 28 years of experience in the field of adult and pediatric therapy. Dr. Ritchie is a practicing physical therapist at Tulsa Sunshine Center in Oklahoma. She is also the owner of No to Change and has educated healthcare professionals both nationally and internationally in some really advanced treatment techniques and specialized practice training and consulting services. She's worked in a variety of settings through her career, including private pediatric and adult clinics, schools and private homes, hospitals, and long-term care facilities. So she's been everywhere. Dr. Ritchie is a credentialed clinical instructor and has taught human anatomy, physiology, and nutrition at Tulsa Community College. She received her associate's degree in 1993 from Tulsa Junior College and has worked as a physical therapy assistant while completing her bachelor's of science degree in organizational leadership from Southern Nazarene University in Tulsa. Dr. Ritchie earned her master's degree in PT from the University of Findlay in Findlay, Ohio, and she continued to expand her expertise in the field. She received her postgraduate doctorate from Rocky Mountain University of Health Professions and is a board certified specialist in pediatric physical therapy. She has served as the treasurer for the Oklahoma Physical Therapy Association and has been a member of that association since 2004. Liesa's passion for helping others extends to her private life as well. She's volunteered as a call rape advocate and Salvation Army volunteer. Her passion for travel has led her to teach and treat overseas, everywhere from Australia to New Zealand, Turkey, the UAE, and Mexico, in addition to organizing and participating in mission work in Mexico, the Ukraine, and Palestine. Liesa's wide range of clinical experience, organizational leadership, and proficient teaching skills have made her an exciting and compelling instructor. And one of the main reasons we have her here today is 13 years ago, Liesa began a comprehensive study in pediatric toe walking. She has since developed a 3-day, 22-hour training course that focuses exclusively on the etiology, assessment, and treatment of toe walking. If you are a therapist who has been tasked with treating patients with toe walking, or if you are a parent who has a child who toe walks, you know that this is a very pesky, I like to call it a pesky diagnosis, one that can be very challenging to evaluate and treat. And Liesa she's the expert in this area. She is who people in our field go to for education on this diagnosis. In full disclosure, we look wide and long for guests on our podcast. And if you've been a listener for a while, our audience is both parents and therapists and other professionals. And so sometimes we have parents and we have all kinds of experts. And Liesa was definitely don't miss your shot, shoot it podcast guest for me. I thought, why not ask her to join us and see if she might happen to consider? And when she replied back that she would like to be a guest, I actually screamed out loud because I really admire her. I admire her work professionally. I admire the journey of her career. I've taken some of her virtual courses through Medbridge, and I have worked in a clinic that is utilizing her specific techniques for toe walking. And I can tell you from firsthand experience, they work. So I am overjoyed and a little geeked out to bring her to your ears today. So I hope that you will enjoy the podcast. We will certainly follow up with links and information of how to find her at the end. But for now, I bring you Dr. Liesa Ritchie-Persaud. Enjoy. Hi, Liesa. Thanks so much for joining us. I just told our listeners all about you and your extensive work. And I also told them that when you replied, you would meet with us and have this chat that I screamed, that you're PT rock star territory for us. And we're just so honored and excited to have you here. For our listeners, I am familiar with Liesa's work and have used her methods with children that I have seen. And I'll just tell you from personal testimony, it works. So if you are a therapist who is joining us, pay attention. This is good information. And if you are a parent who is struggling with toe walking, this is great information to share with your pediatrician or your therapist. I always say toe walking is pesky for therapists and parents. And so if you're joining us, this is the place to be today. So let's get started with Liesa. Can you tell us a little bit about how you decided to specialize in this area of physical therapy?
Yes, well, it certainly wasn't a conscious decision as far as like, oh, I love toe walking. I don't think anybody's ever said that, to be honest. For me, I was fortunate to work at a very large facility for a number of years. We had PT, OT, speech, dietary psych, and dietary and family counseling. And we, with that amount of disciplines and not very many clinics, understandably so, we were super, super busy. And they were probably on average about 400 appointments a day on the books. So it was pretty big. And so over time, we saw, and this was probably about 15 years ago, 15 years now, we saw the increased number of children coming in with this diagnosis of idiopathic toe walking. And quite honestly, we were, and we still are to a certain extent, but we were failing the children, we were failing the families, and we were doing what we were taught. And honestly, what we were taught was not accurate. But I think it's all we knew as a profession at the time. So what we were doing, the child would come in walking on their toes. I'd spend a little bit of time with them, and you're one of those kids. Okay, go to OT. They'll fix you, and I'll make your braces. There we go. Or they'd go to, and I'll talk about this a little bit later. But they'd go to speech. There's a correlation with toe walking and speech delay. So they'd go to speech, and speech would say, "Oh, you have, you're working on your toes. Go to PT." They'd come to me, and I'd say, go to OT, and the parents just overwhelmed, like all these experts are telling them everything that's, supposedly wrong with their child. And the parents, I just came because they couldn't pronounce their R's. So bottom line, what we were doing wasn't working. We were just throwing a bunch of stuff at these kids, and it wasn't working. And I don't fail well. So I had to come up with something different. And that's kind of how it found me. We had to do better than what we were already doing.
That's the best way sometimes to solve a problem, right?
I think so.
Can you tell our listeners what we know about why children toe walk?
Well, what we know, if you Google it, what we know is what we're told. And what we're told is a variety of things. So what we're told is, that most kids do it, and they'll typically outgrow it. They'll do it maybe till the age of 3 or till the age of 7. or, they'll do it maybe because of autism, or maybe because of cerebral palsy, or we don't quite know why they do it. So that's what we think we know. What I know is quite different, actually. I find that what we need to do is identify the cause of the toe walking. Toe walking is not an effective or safe or an ideal way for the human body to get through space, either in the moment or over time. And it does cause damage, and the body will do it to meet a greater need. And so that's what I think we need to know more than what do we know, is what need is the toe walking meeting. If we can identify that, address that, it reduces the need for the toe walking, reduces the future consequences for the skeletal and the muscular systems, and then hopefully without surgery or Botox, no poison, no knives. That's always a good day if we can do no poison, no knives for our kids, So toe walking, it's a pathological movement disorder. It is not a foot and ankle problem. It's a pathological movement disorder, and it's not about the foot and the ankle. So if we address the etiology and address the cause, not merely the symptoms are the range of motion and the walking.
Right.
So that was a long answer to a short question, but what we know is one thing, and I think it's actually very different.
In your experience, what are some of those common things that you feel, even if it's not, documented in the literature, but from experience, what are some of those things that you feel predispose a child to toe walking?
I have got it into 3 different categories, and in my course I go into a lot of detail and teach therapists about that. But there are 3 categories, I believe, and then we kind of teach how to figure out what those categories are, and then the intervention is very different. So the first one is just straight musculoskeletal. So these kiddos, often kiddos with a history of GI, tummy problems or prematurity, will be born with or develop in the first few weeks early after birth. They'll develop shorter muscle length. So musculoskeletal could be shorter muscle length. It could be weakness. Okay, so we're talking about muscles, could be weakness. So there's musculoskeletal, and then there's neuromotor. Now it's not neurological. Neurological, we're talking about some kind of diagnosis, so some kind of insult to the sensory nervous system, cerebral palsy, something like that, TBI, right? We're talking neuromotor. And neuromotor, that's the motor map that the brain has, again, for a variety of reasons, and we can help kind of figure out and dig into that. But the brain has developed a walking pattern that's to be on their toes. So that's because movement doesn't come straight from it's not already predetermined in the brain. Movement comes from how we move. And how we move, we get better at moving that way. And then the third category is the sensory dysfunction. So, and that obviously is a little bit different than the other 2. So, but I think if we figure that the primary contributing factor to the toe walking is sensory, then I'm not going to go straight to stretches.
Right.
It just doesn't make any sense. So we have to figure out. So those are the 3 categories: the musculoskeletal, neuromotor, and sensory dysfunction. Then once we figure that out, we can determine the more appropriate or the most appropriate ways to address it.
That makes sense. And you kind of touched on this, but toe walking can be associated with a diagnosis, or it cannot, correct?
Yeah, absolutely. Yeah. Now, and in diagnosis, there's always a reason. So we have to figure out what that reason is. But then it's often, or it can be associated with medical diagnoses too. The medical diagnosis, yes, it has some relevance, but we're still addressing a movement disorder.
Exactly.
So my approach doesn't change dramatically in the absence or the presence of a medical diagnosis. We're still looking at how they move. The orthotics, for example, the orthotic design that I use, the purpose is to retrain gait, not stop the toe walking. Exactly. So medical diagnosis is helpful as far as giving some additional information and opening up avenues for resources and things like that, for example. But
I often say to my parents, you can go to the doctor and the diagnosis might tell us a little more about what to expect or help us get insurance coverage. But as your therapist, I'm going to do the same thing.
Exactly.
Whether you have it or not, right?
Right, exactly. And they have to be careful with diagnoses too, because if you come back with something, well, of course they walk on their toes, they're autistic. Well, you can always hear doors slamming immediately at that point, and that's just not the case.
Exactly. So. It's not proactive.
Right.
So we asked some of our listeners for questions, and
actually, can I say one more thing about the diagnosis? I just thought about that.
Yeah.
The other thing is that we do have study results that do correlate the toe walking with autism, because I mentioned that. But it's again because it's meeting a sensory need. So it's not that because of the autism, this is how you're going to walk. It isn't. That's not the thought process. It's that, okay, that gives us an idea that we need to look for those sensory systems.
Exactly. That makes sense.
Okay, sorry.
One of the questions that came in from a lot of our listeners who were both therapists and parents was, should we treat toe walking? Does it matter? Should we treat it? And are there known risks to not treating it? Why is it important to address it, basically?
Okay, well, I'm going to try and give you 16 hours in, maybe 16.
No, this is your specialty, and we'll talk more about if people want the in-depth reason for why we're find you before we leave today. But just briefly, if a parent was asking you this question,
right.
Why does it matter? How would you answer that?
Right. Well, I think there's a couple of things, well, more than a couple, but first off, toe walking has a high prevalence among children with a cognitive disorder. So it's, for me, it's a marker for early diagnosis and intervention there. So we don't want to just, brush it off. I think often if there is some kind of overt signs such as cerebral palsy or autism or something, those diagnoses are caught, but there's a correlation with vision difficulties, speech and learning disabilities that are often missed. So that's another reason we need to look at that being an indicator that we might need to look for more things, and we can access resources earlier. And as with most developmental concerns, these problems are best dealt with quickly, efficiently, cost effectively, in order to reduce the potential for bigger challenges to the child's future functional ability. The orthopedic deformities are a big concern, and that's what gives me cause for worry when we're told to kind of wait and see, or so we can address it later, because these deformities, skeletally, once the skeleton has changed, it's very difficult to make changes once the skeleton is formed. And that most characteristics of the skeleton, especially the foot and the ankle, are formed by about the age of 4. And it doesn't mean after 4 we can't improve their gait. It just means that the potential for change is a lot less. So should we treat it? Yeah, we need to look into other things, and we also need to reduce the potential for these somewhat permanent changes that can happen. And the other thing is that a child's balance reactions and how they move and how they achieve stability are consistent and reliable about the age of 3. So a walking pattern is much less likely to respond to intervention after that age. Now we can do it, it's just going to take a little more work. So it's all about proactive. I mean, the toe walkers of 2 to 3 generations ago are different than the toe walkers today. And their management, therefore, has to be different than what we were taught 2 or 3 generations ago.
I can just add to that from a parent standpoint. I have a 15-and-a-half-year-old. So even though I was a pediatric therapist when she was a baby, I was a young pediatric therapist, and I hadn't had any training or experience in toe walking. It wasn't something that we got a lot of in school.
No, we don't, not because nobody knows.
I had 2 children who were very close in age, so life was hectic, and I was working, and I had a toe walker. And she had very defined calves, and she has a very athletic build overall. And her dad is also a therapist, so we would check her range of motion and make sure she wasn't getting tight, and we didn't really do much about it. And I think my theory is she was a gymnast. And so I think she met some sensory needs naturally without structured intervention. Not that I recommend that. I'm just saying, I think that's what happened in my negligence as a parent. And so she eventually stopped toe walking. However, she is a dancer, and she at one point ended up with an avulsion fracture in her foot. And I took her to a pediatric orthopedist, and they heard the history of toe walking. They said, even though she has, adequate range of motion now, her eccentric landing ability is not what it should be because of her history of toe walking. And so they felt that her toe walking predisposed her to injury.
Absolutely. It's the mechanics of the body are completely altered when you walk that way. It's not just so, and even if they can put their heels down, that's not the point. Their mechanics are completely altered. And
and I use that example with parents because I say some children that toe walk will have more, significant medical diagnoses or concerns where other areas of development are affected. And there will be some children that don't have those challenges, but it doesn't mean that the toe walking is not significant for them. And I wish I would have known then what I know now, which is.
Well, you say that about all aspects of parenting, I think.
Exactly.
But we can't, I think, we can't underestimate the seriousness of toe walking itself. It doesn't mean it's all doom and gloom, not at all, but there are future consequences. I had a lot of kids that are bullied, and that's a big deal. It's a big deal. It increased potential for change, for skeletal ossification. It changes with gains in height too. Toe walking is an incredibly unstable position for the body, physically unstable. So when they get taller, then you have issues. And I often find that when we get our kids' heels down, we then have to deal with recurrent ankle injuries and ankle sprains. Because the ankles are just unable to support the body because they never have to do it.
And I've had adults tell me I was a toe walker as a child, and I have had knee pain even in my 20s.
Oh goodness, knee pain, back pain, or
exactly.
Exactly.
It's all connected. So I think that's important in answering that question to parents, that, as you said, there are many reasons of a wide variety to treat it. It's not something to ignore or just wait and see if it gets better.
Absolutely. And if we look at, if we consider ideal development, and this is supported in the literature, toe walking is a part of normal childhood development. It's just not. That in itself is not in the literature. So an ideal development is, but that toe walking is a part of that. When we look at studies of gait, Sutherland, Perry, they're the hallmark gold standard of children's gait development. Toe walking is not a part of ideal development. When we hear these things, these reports are mostly anecdotal. They're passed from one practitioner to another. On average, and this might be helpful for parents and therapists, I think, to hear, typically when they study gait development in typical kids, heel strike is found at about 6 months after they're walking independently. So say they start walking at 12 months, by 18 months, typical kids have, so 6 months of walking by themselves. And then, I'm sorry, what did you say?
I just said great to know for therapists and parents.
It's a marker.
It's a myth. That's normal. That's normal.
Right. And then about 2 years after independent gait, that's when there should be constant, consistent heel strike. And there's actually a really great study done. I think it's done in 2005 by Nancy Dilger. She's a PT in California. And it's widely available on the internet. And if people, email me, I can send you the reference. But she looked at all of the studies out there for gait to answer that question: is toe walking part of ideal development? And there was a resounding no. It's a really great article to read, and then she lists all the references that she looked at. So if you want to kind of really get deep into ideal gait, that's a great resource. So if people contact me, I can send them that.
And we can link that article. We can also link resources, so we can definitely do that. You mentioned vision briefly. So my next question is, are toe walking and visual challenges related? Yeah,
absolutely. Well, yeah. The kiddos will pass an eye test, though. They'll pass an eye test just fine. They don't need glasses.
Yeah,
exactly. That's exactly it. It's acuity only. Where the toe walking relationship comes in, it's not about can they see. It's rather about how they interpret and utilize what they see to adjust and optimize their posture, their movement, their gait, coordination. So it's not, can they see what's in front of them? It's how do they use visual information from the environment to affect how they move?
Right. I tell parents all the time, vision isn't just your eyes, it's your eyes coordinating with your brain. So
exactly. On my website, there's a link that people can click on. It links to the College of Visual Development. It's covd.org. You have to be careful because it defaults to covid.org now.
Yeah.
So make sure it doesn't auto-correct you. Surely we're asking about COVID. No, it's covd.org, which I never had to say that before, but I do now. And that's I think it's College of Visual or Vision Development. And that explains exactly what I've just said. What on earth does vision have to do with how you walk, and it explains it in a lot of detail. It's a good resource.
So if you suspect vision is potentially affecting the toe walking, or just to be comprehensive, you want vision looked at, do you suggest developmental optometry?
Yeah, that's exactly what it would be, as opposed to typical just a regular optometry. I mean, they have a need, obviously, but not for what we're
not this.
It's a little tricky in that insurance coverage can be sporadic, but sometimes though you can go for the exam. They're aware, these developmental optometrists are aware that it's not always covered, and so they'll often work with you on how to do things at home. On that website that I just told you about, you can search for developmental optometrists by zip code, so you can see who's in your area. And then also, again, on my website, there are a couple of resources written by developmental optometrists for parents. One is called Eye Games, and then another one is called Seeing Through New Eyes by Dr. Kaplan. So that's what I try to do on the website, is like where you can click on links and go to that. So there's a couple of resources. And I Can Learn is another one. EYE Can Learn. It has a little ladybug in it. That's another good resource too. Yeah.
I find that, at least in our area, a good developmental optometrist is also very willing to work in coordination with therapists. So for the therapists out there, check out who your local developmental optometrists are and have a conversation with them about toe walking and how you could collaborate together potentially.
Exactly. Yeah.
Let's talk about baby walkers and bouncers, I call them containers. I'll write on the keep them out of the container, please.
Right.
Does that increase toe walking?
Yeah. Obviously, we don't have any research on that because really nobody's looking. There's one study, unfortunately, it wasn't a super strong study, but I think they were really onto something. And they saw kiddos that used baby walkers too early. So early meaning before they were pulling up and weight bearing themselves. So before they were cruising. So they used the walkers. And they found that those kiddos on EMGs, these are typical kids, but they used the baby walker too early, and they had the same movement patterns as kids with spastic diplegia. Mm-hmm. So we created a toe walking or a plantar flexion position with that. I think that if there's already a problem, if the kid's already having challenges, that baby walkers and bounces can perpetuate the issue. Baby walkers are also correlated with much greater accidents and head injuries. That's a whole other discussion. I have a little webinar on that, but that's not related to toe walking. And also the walkers also do promote more extension and flexion, which correlates with toe walking, poor balance, weakness. The thing with the bouncers and the containers and all that stuff, the baby walkers, the kiddos might still achieve milestones on time, but it's the quality that's affected. Mm-hmm. And then the quality then becomes very evident in early childhood. Yeah. So they'll crawl, walk, all that stuff according to the charts, but the consequences and how it affects their ability later on is where we see that. And so I just think you don't know if there's an issue necessarily, but excessive use of those things can make that issue worse. Yeah. It's all about quality over milestone acquisition.
Exactly. We want good motor movement patterns for longevity.
Right. Exactly. Because that puts, and when you talk about longevity, you're exactly right. Abnormal movement patterns put strain on the tissues. Abnormal mechanical stress on the joints. You might not see that until they're 14, 15 trying to play softball.
Right. And I always, one of the courses that we have for Medbridge, we're actually doing side-by-side videos, kind of like that Who Wore It Best with celebrities, where you have a baby in a container and then you have a baby on the floor, and just watching the movement patterns of what's available to them when they're not strapped or contained, and explaining how every little wiggle, rotation, turn is an exercise, right? So not that, putting a child in a swing for 5 minutes while, or 10 minutes while they take a much needed shower is the end of the world. But if they're spending excessive amounts of time in there, what are they missing out on?
Absolutely.
And so I drive that. It's interesting to know too, that there can be an effect with toe walking too.
Right. And it's sport specific training. If they're in a baby walker, they're going to get really good at walking in a baby walker. And they're not going to get good at walking out of one. Exactly. I think the guidelines are 30 minutes a day in some kind of container device maximum. That's the.
What about shoes? Are there certain shoes that decrease toe walking? What are your feelings on shoes?
Nope. Walking gait comes from the brain, not from the feet. It's that simple.
Okay. So there's not a specific brand you like?
Nope.
No feelings on bare. Do you recommend bare feet?
Barefoot is best. I always say barefoot is best in the absence of a pathology.
Correct.
Now, the ongoing kind of discussion that I see between therapists is, well, I want them to feel the floor, and if they, I don't want them to become dependent upon the shoes or dependent upon the braces. I want sensory information. They're not going to lose sensory information I'd say 25% of the time barefoot if there's an alignment or a movement problem. You're not going to obliterate sensory info. The tricky thing is when there is a movement problem and they are barefoot, they're getting information all right, but they're getting inappropriate information. Right. And that's how our movement happens. And so
we want them to get the information in correct alignment.
Exactly.
And not receive correct alignment on their own.
Right, exactly. But shoes are not going to change toe. You might think they do because you can't see their feet because they got shoes on, but it doesn't affect the toe. Toe walking comes from the brain. It doesn't come from the feet.
Okay. One question that we get a lot is, when should a parent take their child to see a PT if they notice toe walking? What age? Would you go back to those guidelines of 6 months after?
Yeah. I'm going to give you some pretty kind of specifics, actually, but these are also, there's a little handout, and I'll tell you how to find all this at the end. But there's a handout on my website. You can click on it and print it. So I'll give you this info. But if you're driving, listening to this, don't think you're going to miss it all, because you can easily, you can get that. Okay, so signs when it's a cause for concern. I'd say if you notice that your child's walking on their toes more than on their heels, or if they show infrequent kind of heel to toe contact, infrequent heel to floor contact. So if the heel's not touching the floor, they might look as though they have kind of a bouncy walk if their ankles are stiff. And if you find yourself saying you look like a ballerina, it might also be, and in fact, there's also a Medbridge handout. I just realized that includes this too. So that's another place for people to go. I'd be concerned if the first part of the foot to come in contact with the ground is the front of the foot, and your child has been walking for longer than 6 months. That's a pretty good indicator there, because that's not in the parameters of ideal. Does your child dislike their feet being touched? Do clothing tags bother them? Any kind of clothing bother them? If they don't like getting their hair brushed, if they don't like getting their hair washed, are they clumsy? Do they fall often? Bump into things? Do they fall over their own feet? Car sickness much after the age of 3 is a little bit concerning. Do they have a delay of milestone achievements? Do they love spinning or that kind of activity more than other children? Couple other things: if their ankle flexibility is getting tighter, or if they have difficulty standing on flat feet, even if they try. And then also if they were premature, low birth weight, or if they have difficulty with speech or learning. So those would be, and again,
those are great, very detailed.
Yeah, those are big ones. There's a Medbridge handout, and there's also one on my website too. They're slightly different. Kind of in relation to that, I'd also say that signs when it might not be cause for concern, because your child might not actually be, quote, toe walking. It could be a short-lived developmental stage, but it looks very different to problematic toe walking. So I wouldn't be overly concerned if they take a few steps on their toes and then they return to flat foot after a couple of steps, or if you're seeing that, quote, toe walking reducing in frequency, or if they've only been walking independently for several weeks. So I wouldn't be overly concerned about that immediately. Yeah.
Okay. And you touched on this briefly, but what are your thoughts on Botox, casting, intervening that way for toe walking?
Okay. So my approach is to retrain the gait pattern. It's not to stop toe walking, it's to retrain the movement. And I just don't find personally that Botox is conducive to that outcome. It might temporarily improve range of motion, but shortened muscle length is only a symptom. I prefer to address the cause. And with regards to casting, if casting is done appropriately and individually for each individual child to retrain gait, then it can be very successful. If the approach is either to stop the toe walking or to stretch the muscles, I would question whether long-term results are likely. And by long-term, I'm talking a few years. Mm-hmm. A few weeks after it's not long enough to make a determination. And then surgery, surgery, now there's definitely a time when surgery is appropriate, and I'm not saying that all surgery is bad, but I think it should really be an absolute last resort. And most of the time, just because of our lack of knowledge, we haven't tried everything. But again, surgery, it can temporarily improve range of motion, but again, shortened muscle length is only a symptom. The research related to surgery in toe walkers bases the results on outcomes like range of motion or do they achieve heel contact? And that's not addressing the gait patterns. So sustainable changes in gait and movement are often unusual and post-surgery for, you can sustain it. They typically have to go back and have repeated surgery, but that's just dismissed as because they grew. Oh, well, they grew as the toe walking comes back. I can't say it enough. Children don't walk on their toes because they grow. Right. They might increase the toe walking when they gain in height because they're more unstable or they have muscle inflexibility. But kids don't walk on their toes because they grow. It doesn't happen.
That makes sense. And that's all good information. We touched on this briefly. I feel, and I know you agree, that this is a grossly underserved area in physical therapy. And once I became familiar with your method and your work, I won't lie, I cringed at the amount of kids that I know were going through more invasive interventions that maybe didn't have to, right? If there was more people that knew about your method, knew about this work, to just give it a try before other options were given. So for the therapists out there who, work in pediatrics or maybe even work in outpatient, but get a lot of toe walkers from the local pediatrician, just depending on where they are geographically, or for parents who are, go-getters and doing research on their own to try to intervene for their children or find ways to do that. Can you tell us more about where to find you, what kind of courses you offer and the differences between them? Because obviously we're not going to touch on all of the detail here, but Liesa's methods are very specific, trainable techniques that can affect a large number of children. So can you tell us a little bit about that?
Of course, yeah. I think, first off, that when you said about you kind of cringe at the kids in your past, I think that's common for every therapist and every parent. And I think that if you're not doing that, then that might be cause for concern in itself. So I think the bigger sin is knowing better and not doing better. I think it's like
that that quote from Maya Angelou, when you know better, you do better, right?
You better, yes.
And so we're all always learning. And so that's
So
why
don't
you're
beat
here.
yourself up for- No, you can't beat yourself up. Think of the kids I practiced on 15 years ago. I mean, that's cringeworthy. You know?
Yeah.
And the thing too is I think we don't always have confidence in ourselves as therapists. I'll talk to the parents about that here in a minute, but as therapists, we don't always have confidence in ourselves because, well, you know, it's not what the research says, or yeah, I got it. But evidence-based practice, when it first was developed, was based on three concepts. It was client values, so the parents and the kids out there, clinical expertise. I've been doing this for 30 years. I've been doing nothing but toe walking for 15. So I picked up some things along the way. So clinical expertise and scientific research for sure. But I think unfortunately at some point, evidence-based practice became research-based practice. So just go back to the evidence is the clinician, the family, and the research. I always kind of ask myself, you know, this is great. I want to know how useful will this information be on Tuesday in the clinic? That's what really matters. And can families and therapists use the information? So, okay, so my different courses on the website is I think it's pretty comprehensive. But there's different pages. The Medbridge courses, these are designed as a kind of an intro to my philosophy. So that's a good place to start if you want to know more. And you can kind of see if that's okay. Is this something else? Is this something I want to go further down that path? If you access them through my website, you get a discount that way. So that's just a bit of helpful info. Live web, I don't do any teaching in person. Live webinars, there are 3 different ones. I would suggest the toe walking first because it really is, well, obviously for this subject, it addresses everything comprehensive, but that'll give you a good solid foundation with for things to go and use. And then, so that's toe walking. The second one is the sensory gross motor. I would, again, you can take any of these in any order, but my suggestion is the toe walking followed by the sensory. The sensory gross motor flows really nicely from the sensory component that we begin to look at in the toe walking course. And my third one is delayed onset of gait, which that one kind of, you know, no pun intended, but that one stands alone.
Yeah.
There are recorded, so those are the live ones. There's recorded. The toe walking and the sensory are available as recorded versions. The delayed gait course is not available recorded because the final part of that is a lot of live group discussion back and forth between everybody of different case studies. So that doesn't really lend itself as well to being recorded. And then there's a part B to walking. Part B, back when I used to teach live, part B was filmed as the final component. So I don't do that live anymore, but that's the part B of toe walking, and it's me teaching at a seminar. It's not a webinar. It's me teaching live at a webinar. That one addresses, it touches upon reflexes. If you want to know more about reflexes, do not go looking to me for that. Janine Wiskind at Education Resources, phenomenal for reflexes. So that's where you go. And we do expand upon vision in that course. And we also explain further how to use my assessment tool. The assessment tool's in the first one, but that part B, we go into it in more detail. There's therapeutic services recorded. That's how to recruit the core by optimizing foot alignment. So instead of doing sit-ups, if you give them good foot alignment, they'll recruit their core with every step they take. So that's a little bit more feasible on a Tuesday than sit-ups for a 3-year-old. And then finally, Nalero 24, these are all on the website. Nalero 24, these are recorded webinars. They're about an hour or less. They're designed to be more informative as opposed to instructional. 9 topics for clinicians that are not addressed in any of the other webinars. And there's also, I just did this one, a recorded parent webinar as well. We touch upon toe walking, touch upon foot alignment, and there's one other, like balance and postural control as well.
Okay.
Links to all of those on the website.
And the website is, we'll link it, but can you just?
Yeah, okay, so the website is knowtochange.com. So it's KNOW as in no, so KNOWTOCHANGE, know to change, because I want you to know to change when something isn't working, okay? You can email me directly from that website as well.
Social media links there too, Medbridge links there.
Exactly. The Medbridge page has links to other webinars that I recommend that have got content related to what I talk about in the webinars. The live webinar page has links to those courses that are currently scheduled. If you don't see a live webinar date that works for you, then just email me, because that list might not be completely comprehensive, or you might want to schedule a private one for your own group. Parents and clinicians can do that.
That's a great idea.
Yeah, and then also, so the contact form is on the front page. Yeah, and then there's also the Knowledge Nook. That is a page that's divided into clinicians and caregivers. And there's resources such as websites, articles, books, and other readings of interest.
I love that.
To Know is the page that gives therapy resources. There's the shop. Now the shop, I don't make a profit off what I sell at all. I'm not in the distributor business. I'm a therapist. But often when I mention the supplies that I use for the shoes, for example, to modify the shoes, the manufacturer has a minimum order. So sometimes if you just want a couple of things, you can't get them from them. So that's why I sell them, because I can buy them, in bulk. How else to get a hold of me? Oh, the subscriber list. The bottom left of all my website pages, you'll get onto my subscriber list. There's no spam. That's just a way for me to share information related to course content. And there's one email a week. That's it.
Great.
And then, one more, there's a Facebook page. That was the other thing. There's a Facebook page by the same name, Know to Change.
Okay.
If you do Know to Change and then put my name after, you'll find it. Sometimes Know to Change on its own gives you a lot of political pages. I want to avoid that.
Yeah, that's funny.
If you Know to Change and then Liesa Ritchie, yeah.
And we will link when we post this on our website, on the podcast feed, on our social media. It will all be linked back to Liesa. So if you're coming there, just go back to the post and there'll be a hyperlink there.
And that's a huge amount of info. But basically, if you just get them to the homepage, knowtochange.com. After that, it's pretty self-explanatory. Yeah.
Okay, great. And then one last question. We always ask our podcast guests at the end of sharing all their knowledge and expertise. If you had the mic, what's one thing you want our listeners to know? It could be about toe walking or physical therapy. It could be about life. Just what do you think people should know?
I would say, as a parent, don't assume that you don't know because you're not a doctor or an expert or a therapist. We might be experts in areas of our field, but you are the expert on your child. And don't discount that, because it gives us an incredible amount of information. Help us, help you, help your kid.
I just got goosebumps because you're right.
I got choked up when I said
I know.
that.
Well, it's true. I mean, I think when you've been a therapist for a number of years, you're very tuned into what parents are going through, and they just want the best for their child. And, I always say to parents, I'm here to help you learn this, but you're here to help me learn about your child, because no one knows them better than you. Right. And I think you're exactly right. I think that's important for parents to be reminded of. So thank you for that reminder.
Thank you for doing this for parents. I really don't, I think this meets your podcasts, I think, meet a need that's not met in the same way anywhere else. And it takes a lot of time. I know it does. People have those of us that have some kind of platform, people have no idea how much goes on in the background. Yeah. And then when you commit to something, you kind of have to follow through. So Thank you for doing this.
And I also encourage other therapists out there, when we do look at the research of how parents learn, we know that multi modes of information are most effective, right? And so I think with this generation of parents, we're getting away from handouts consistently being the answer for education. And in a digital world and a busy world, parents like podcasts, they like websites. So sharing online resources, oftentimes I'll say, this is part of your home exercise program. Listen to this podcast on toe walking so you can understand why we're looking at this, or what our goals are, what our approach is. Because an educated parent is going to be bought into what we're doing as therapists. For sure. So anybody listening, any of our episodes, feel free to share them as part of your home exercise program or general education. That's what they're here.
Real. Put it on your listservs. And therapists are very respectful of parent serves. I think a lot of times we try not to get into your territory, and but I think a lot can be learned from one parent to another. So.
Absolutely. Which is why we sometimes have parents as our guests on the podcast, because we can learn from them as well. So thank you again for your time, Liesa. Thank you, listeners, for being with us today, and we will catch you soon.
Great. Thanks. Bye, everybody.
Bye. I hope that you all found that as helpful and as inspiring as I did. I am really hopeful that this podcast can be used as a resource for parent education, for therapist education, and to help us all work together to reach as many kids who are challenged with toe walking as we can. As mentioned, we will link all of the information Liesa shared with us on the podcast listing and also on our social media links. As always, you can find a plenitude of resources under our website at milestonesandmiracles.com, including 123 Just Play With Me, some great downloads and free resources, and a link to our Medbridge subscription for the therapists out there with a discount code. If you have any questions, don't ever hesitate to reach out. I hope you have a good day. Thanks, as always, for joining us and sharing some of your time with us. And don't forget to take time to play. See you next time.